Thank you for joining the fifth and final session of our Coker ValuePath mini webinar series. It's a privilege to have you join us. Our topic today is marketing of value-based care delivery. Hopefully you got a chance to pre-submit your questions, but if not, you can submit your questions to me via email at sburnett@cokergroup.com after the presentation, and we will answer your questions at that time. After today's presentation, if you would like more information on the topics discussed and how they affect your organization specifically, please reach out to me directly and we will coordinate a time for you to speak with one of our associates. The participant phone line will be muted for today's presentation, and the materials will be emailed to you shortly after the conclusion of the session. The slides from today's presentation as well as past sessions are available to download as a handout in the GoToMeeting dashboard. Recordings from previous sessions are available upon request. Finally, as you exit the webinar, a brief survey will pop up, and we would greatly appreciate your feedback on this presentation. Today's discussion will be led by Dr. Ellis McKnight and Jed Sudduth. Please join me in welcoming Dr. Knight and Jed.
Thanks, Savannah, and welcome everybody to the final mini webinar series, our ValuePath mini webinar series of Coker Group. It's been a pleasure presenting these series over the last 5 to 6 weeks, and I hope you have gleaned a lot of good information from them. As mentioned, my name is Mac Knight. I'm the Senior Vice President and Chief Medical Officer at Coker Group, and joining me for today's session is a long-term colleague of mine, Jed Sudduth, who has a lot of experience in healthcare as it relates to the business side of healthcare, and so I very much appreciate him helping me as we present to you a session that really talks about the business aspect of healthcare and how the whole shift of volume to value does not necessarily need to mean the demise of your business performance, but for the astute organization who takes advantage of some of the new opportunities that can be opened up by moving to a more value-based care delivery system, can really help you to, again, improve not only your clinical performance, but your business performance in the delivery of healthcare services. So I'm going to talk to you at the first of the session and really give you kind of an industry overview, again, about this value-based shift that's occurring. And then Jed's going to talk to you about some specifics that you may want to consider in terms of marketing and contracting and sales of value-based care delivery and where those opportunities lie out in the market. We've only got 30 minutes, so unfortunately we won't have any time at the end to answer questions, but we'd certainly be glad to take those offline and follow up with any of you who may want to explore this topic in a little bit more depth. So let's jump right in. I think all of you know that the major trend across the industry since 2010 with the passage of the Affordable Care Act has been this move from a more volume-based business model in healthcare to a more value-based business model. And again, we define value as quality per unit of cost, or quality divided by cost, which is really, I think, the newest wrinkle on the quality movement, where we've been emphasizing quality and patient safety in healthcare for some time, but now with the escalation in the inflation in cost of care across the U.S. healthcare system, there's more and more emphasis on that cost component of the value equation and trying to get that under control. We're seeing this move from volume to value play out in a number of ways, but I think the most tangible evidence of that is what CMS what Medicare and Medicaid are doing in the marketplace. They released the preliminary rules regarding MACRA, which is the new way that doctors under the Medicare system will be paid going forward on a value-based basis, and that has really been a shot across the bow that this whole value-based reimbursement move is real. CMS is also demonstrating that they are very, very much convinced that bundled payments are going to be a way to incentivize higher value health care, again, more high quality and lower cost, and also better coordination of care and less fragmentation of care. And we're seeing a lot of movement in terms of CMS rolling out bundled payments for everything from total joint replacement to coronary bypass surgery to acute myocardial infarction, and others are surely on the horizon. Lastly, there has been a distinct wake-up call or reaction, if you will, from consumers of healthcare in the healthcare industry. More and more of us are covered by so-called self-directed health plans or high-deductible health plans, and that has made many consumers a lot more demanding of transparency and cost efficiency in terms of the pricing in healthcare. Likewise, large self-insured employers who are footing the bill for their employee population are looking for value in the marketplace. So the consumers of healthcare are now driving a lot of this change along with the payers. So again, the name of the game, we believe, is value. And again, we use this value equation all the time. Value equals quality per unit of cost. And I would say that this is truly the overarching imperative in healthcare right now. We talked about the move that CMS is making, and I would also say that commercial payers, as they usually do, are following CMS's lead. So we're seeing a lot of commercial payers also paying under a value-based reimbursement model. Blue Cross Blue Shield is doing a number of pilots where they are bundling payments for services like total knee replacement. Aetna has a number of their so-called Aetna ACO models in the marketplace right now. Last time I looked, I think there were 70 some of those across the country. And again, this is a similar payment model to the Medicare Shared Savings Program, Medicare ACO program, but this is a commercially sponsored program. And then some of you may be actually participating in a program called the Comprehensive Primary Care Plus program. This is an all-payer program that not only includes CMS but also commercial payers, and it's a way of paying for comprehensive primary care services, again, in a value-based bundled model. So what would we say to you, the healthcare providers that are listening in on this call, would be the benefits of your trying to transition to a high-value care delivery model from a business perspective? Well, first of all, we believe that even in a fee-for-service model, even if fee-for-value, bundled payments, capitated payments, even if those don't materialize anytime soon, it is absolutely true that cost control, cost efficiency is going to improve your margins or allow you to maintain your margins in an environment where fee-for-service reimbursements are probably going to be flat or declining over the near future. So even if fee for value is delayed somewhat in your marketplace, some of the things we're going to talk about today and some of the things we've talked to you about on these ValuePath webinar series are going to be of value even in a fee-for-service model going forward. In the fee-for-value model, such as bundled payments, again, this is truly a way that you can operate successfully and move into that model and do that in a way that will benefit you financially and from a business standpoint. And the way that that really works is that, yes, there are shared savings to be had, and as we look to eliminate waste and inefficiency in the healthcare system, there are savings that can be materialized and recognized and can accrue to those providers that do that hard work of freeing up those savings. But even more, we believe that the healthcare providers, hospitals, healthcare systems, physician practices, surgery centers, those groups that learn how to provide very high quality care in a cost-efficient fashion will be in an advantage in terms of capturing the greatest share of the market that is growing out there for value-based contracts. And again, what do those contracts look like? Some of them are shared savings agreements, bundled payments we've talked about, capitation is coming back. There are lots of commercial payers that are out there setting up so-called narrow network health plans, and usually those have a shared savings component to those plans. Some large providers, some not so large providers are rolling out their own health plans, and certainly doing that in an effort to capture not only the greatest market of these value-based contracts, but also a greater share of that premium dollar. And then, and Jed's going to talk to you more about this, but there are the direct-to-employer agreements that are becoming more the norm, where large self-insured employers are going directly to providers and looking to contract for services. So how do you do this? Well, the first step is to retool your care delivery system so that it reliably delivers high-quality, low-cost healthcare services. And that's easier said than done. As a long-term healthcare provider, I can tell you that most of us have practiced in a model forever and ever where volume production was the name of the game, not value production. So paying more attention to costs and cost efficiency is something that we're all going to have to learn how to do. And there's a lot of tricks to that, but there are systematic methods to do that and to drive down cost and to deliver care more cost efficiency. And then the second step, once you've done that, is to take that care system that you've now designed and built to be a high-value care system to the market. And again, Jed's going to talk to you a little bit more about that in just a minute. So just in graphic terms, let me use this next slide to demonstrate to you again how this can be of value to you upfront in a very quick fashion in terms of financial benefit to those providers that do go down this value route. So we've got aggregate dollars here on the y-axis, we've got time on the x-axis, and we've got this projected medical loss, or and that's an insurance term, but that basically means the cost associated with delivering health care. So if that cost, as you can see, goes flat across time, as is represented by the large blue arrow pointing to that flat line there, then again, you really haven't freed up any savings or created any profitability for yourself in terms of bringing these savings into the organization that's doing this higher value care delivery. But if you can bend that proverbial cost curve, which really is not just flat right now, but is going up over time, if you can bend that down as demonstrated by the line that the large green arrow is pointing to, then the difference between that line and the flat line is the savings that can be materialized, and those can be put in your pocket. Those can be used to develop more of a value-based infrastructure with costs that are going to be required to do that, like IT systems, like care management staff, and so there's I think a lot to learn from studying this graph and understanding how this works and how you can free up those savings for your own utilization. So the key takeaways to prepare for value-based reimbursement are to identify and redesign your care process delivery system, and especially to emphasize those things that you do, what we call care process units that drive the majority of your costs. Develop a baseline understanding of the cost per case on a per minute basis for each of those processes and procedures. Establish some target performance measures, both quality and cost, for each care process. Track those data points. Use those measures to practice data-driven continuous care process improvement. And then once you've got that system in place, once you're moving toward this more high-quality, cost-efficient model, take that to market and begin to do some contracting. So I'm going to turn it over to Jed, and he's going to talk to you about that step once you've moved down this pathway.
Okay, thank you, Mac. Once you have completed retooling your care process and you're now ready to increase your market share, and essentially what you've been able to do is through the retooling of the care process and also by implementing the activity-based or time-driven activity-based cost accounting system, you can define your true cost of delivering the care. So you're answering that value equation of value equal quality over cost. All right, you can take that newfound ability to the market and increase your market share. Now, where do you take it? There are probably three major places you can take your capabilities to. One is the payers, either government or commercial payers. The second one would be large self-insured employers, and the third would be providers. In other words, you become, if you're a specialty provider, you become part of a current clinically integrated network that doesn't have your capability, and so you supplement them. Of those three, probably the most exciting these days are taking your capabilities to large self-insured employers. The National Manufacturers Association up in Washington, D.C. identified the cost of health care as being the one most important issue that all the U.S. manufacturers want to get a grip on in order to maintain their competitiveness around on the world stage. And so they're very, very serious about it. So that's a very good place to go. Next slide. You can look at some specific examples that would provide opportunity. In other words, in the government payer area, you have MACRA and the programs they've created. You have the bundled payment, comprehensive joint replacement, cabbages and hip fractures, those bundled payment issues that are being driven by CMS. In the commercial payers, you have Blue Cross Blue Shield, and they've run arrangements where they want to do total knee replacement bundles. Aetna, that Mac mentioned, is highly involved in these AC accountable care organizations, and they're looking for partners to be able to deliver high quality, lower cost health care. Government and commercial payers are going after this comprehensive primary care program. Now, large self-insured employers are really taking an initiative. You know, Walmart, Lowe's, and Home Depot have created arrangements with Geisinger in Pennsylvania and other health systems. Intel Corporation has been very aggressive out in Portland, Oregon, and driving the healthcare systems out there to reduce costs. As a matter of fact, in one diagnostic area of low back pain with Intel employees, they were able to drive costs down about 24%, under the headache diagnosis 49%, and under the joint pain diagnosis about 33%. They sent in their lean manufacturing guys into the healthcare systems to help them figure out how to do it better. And then the last example would be that where you as a very specialty provider can supplement or augment a current clinically integrated network. So why do you want to do this? Well, essentially, you've done something that nobody else has done, or very few people have done. You have started answering that value equation of quality over cost. You're bending the cost curve, and you need to receive the rewards for that because of your ability to know what your true costs are and your care process delivery re-engineering. You can get control of your own destiny. You can do direct contracting with self-insured plans to manage their care on specific populations. And I think this fourth bullet point is absolutely critical. As a provider, you know how to manage care better than any third-party payer does, any insurance company. Right now, care is being, quote unquote, managed from what I call the inside out. In other words, you have the insurance company that has the case managers, the care managers, and their care coordinators, and they're putting pressure on providers all the time to try to do this and do that, and change this way and change that way, where the providers are really the ones that know how to do it, and they can manage care from the inside out, and you don't need all the overhead that's created by the insurance companies. And I think that's that overhead can be used for care management, not administrative things. To the next slide. So how do you do this? Well, you have implemented your time-driven, activity-based cost accounting, so you know what the true cost is for managing some episodic issue like let's say, hand surgery or knee replacement surgery or whatever it may be, or you know the cost of managing the chronic care for type 2 diabetes or COPD or whatever the chronic disease is. So you really have a good grip on that. Then from that information, you decide, what would be an acceptable net profit you'd like to receive for your work, for your care management, for your managing the chronic disease patients, or if it's some type of surgical procedure, for managing that. All right. Then what you do is you take your newfound capability, whatever that may be, and as an example, let's say that's hand surgery. All right, let's say that you've really solved that value equation on hand surgery, and so you find the self-insured plans, all right, in the community, in your geographic area, that are going to have where there's a high frequency of that type of problem. And you can do it either from the health insurance aspect or the workers' compensation aspect, right? And you go to those self-insured employers, and through their broker, all right, or someone, or maybe going direct to them, and you find out what their costs are. What are they paying for that hand surgery? And so let's say that you go through their claims data, and you go through the claims information, and you find out maybe they're paying, $15,000, from beginning to end for this hand surgery. All right, because of your cost accounting that you can do it for $5,000. All right, you decided you want to make a, net. I'm just using hypothetical numbers here. You want a net profit per surgery of $5,000. So you go back to the plan and say, well, look, we can do this for $10,000. You're going to save $5,000, and we're going to be okay too. So, you have to work with them to discover that difference, and then be able to provide them with the ability to save money. Now, I was talking to several large national, international benefits brokers the other day, and they said there isn't a corporation out there today, large Fortune 1000 corporation, that if you approach them with the ability to manage either chronic disease or manage surgeries or whatever the episodic problem may be, that they will not sit down and negotiate with you, because they are determined to get a to get a handle on these healthcare costs. So that's really from corporate America's standpoint, the timing couldn't be better for doing what we're doing. For going to this high value care delivery system, because they're ready to do something about it. Next slide. So the benefits of establishing yourself as this, high value care delivery system is really, you achieve recognition as a value-based preferred provider in the eyes of a lot of people, payers, patients, partners. In other words, you become, in the community, in the geographic territory, the folks that have really done a lot of good work to be able to deliver high quality, lower cost care and taking care of patients, which is what it's all about. All right, you get to access, untapped potential, by improving quality and efficiency continuously going forward. So, you just don't do it and then stop. That value equation it's constant, and so you're always reevaluating that value equation of quality over cost, and refining it and refining it and refining it. Now, if that study that was done by the National Institute of Health is right, saying that almost 30% of all the money spent in healthcare, there's no evidence for it being spent, and it was essentially waste. I don't know if that number's right or wrong, but somebody seems to think it's right. All right, you have a huge opportunity, I think, in being able to help not only corporate America, but there are a lot of self-insured plans out there that are governmentals. In other words, states, counties, cities that are all self-insured that you can work with. Also, they're a little bit more difficult because of their governmentals, and they can't make decisions quickly, and they have to go through request for proposal processes and things like that tend to slow them down. So the Fortune 1000 is really the place to be. You increase patient, physician, and staff satisfaction. I mean, I can just visualize a surgery center or a physician's office or a hospital OR where they're really doing good work, high value work, really feeling good about themselves. The patients are really delighted with it. The physicians are delighted because of the high efficiency and the high quality work being done, and the staff feels real good. They're part of something unique and better than anything else around. And you add new relationships with employers and self-funded plans. In other words, this is all about, if you can visualize a community, a geographic territory where there are three providers, whoever does this first is going to get the market share, and they're going to be the ones that are going to benefit for this. So, in preparing for, really the call to action, I think, is, in preparing for the future today, either on a fee-for-service reimbursement type of model that's out there today, or value-based reimbursement model. By redesigning the care process, you'll win in either one of those, but you'll certainly be ready for the value-based reimbursement down the road when that comes to your geographic territory or your community. Mac, that's about it for me. If you'd like to wrap up, please do.
Thank you, Jed, and again, thank you all for spending a half hour with us. I wish we had longer, but again, if you have questions, if you would like to know more about this topic, here's our contact information. These slides will be provided to those that registered for this seminar, and we will be glad to entertain any questions or provide you with any further information you would like offline. So thank you, Jed, for helping me with this today, and again, thank you all for tuning in.
And again, we would appreciate your feedback on this presentation through the survey as you exit the webinar. Thank you and have a wonderful day.